Hello, hello, happy Monday. If you didn't have a Monday meltdown, what's a Monday, right? All right, good evening, wonderful viewers, and welcome to another episode of Know Your Pharmacist, where we unravel the mysteries of medicine and bring you to the forefront of pharmacy, right to your very screens. I'm Dr. Joaquin Acosta, your host, CEO of Pharmtrue, and a passionate advocate for integrating cannabis with traditional healthcare to revolutionize personalized medicine. Tonight, we're diving into a variety of compelling topics that affect each of us, from the bewildering world of generic drug prices to groundbreaking treatments in breast cancer care. We'll explore how the pharmacy landscape is more than just a transactional space. It's a dynamic field where science, policy, and patient care intersect in fascinating ways. In our Pharmacist Frontline segment, we'll dissect the staggering variability in drug pricing and what it means for you. We're peeling back the layers of this complex issue to provide clarity and actionable knowledge. Following that tech talk, we'll shine a spotlight on cryoablation for breast cancer, a promising approach that's reshaping how we think about cancer treatment for older women. It's all about enhancing quality of life with cutting-edge science. And in a deeply personal discussion during our Enlightenment Hour, we'll address the critical need for trauma-informed psychiatric care. It's time to challenge the status quo and advocate for practices that truly support recovery and dignity. We'll also venture into the herbal wellness corner where we can decode the interactions between cannabis and conventional medication, bringing light to your questions and concerns with expert insights. Join us, leading experts and pioneering voices in each field, ready to share our knowledge and answer your questions live. So get comfortable, grab your notepad, and prepare to be informed and inspired. Remember, knowledge is not just power, it's the key to wellness. So let's embark on this journey of discovery together, pushing the boundaries of what we know and transforming healthcare one topic at a time. Thank you for tuning in, and let's make this an incredible evening. All right, so jumping right on in. Pharmacist Frontline segment. We are absolutely unpacking generic drug prices, something that is incredibly relevant to all of us, whether we know it or not. So let's take a good look here. Some good points here about the MedPAC trying to wrestle, right, with wide variation in generic drug prices and availability. So anyways, why does one particular antipsychotic drug cost $1.06 at the point of sale and $102 at another? So members of the Medicare Payment Advisory Commission, otherwise known as MedPAC, looked for answers to that tricky question at their meeting in Washington last week. The antipsychotic drug is just one of the mysterious supply chain complexities that influence the dramatic and irrational variation in availability and prices of generic Medicare Part D prescription drugs, sometimes even within the same pharmacy chain. So from a document developed by the MedPAC staff, commissioners learned that the price of a generic Part D drug was based on the cost of the ingredients, a dispensing fee plus a pharmacy fee, which pharmacies pay to the plan sponsor but are not public, although they are reported to the Center for Medicare and Medicaid Services, aka CMS. However, there are many other elements that influence the price at the point of sale, and much of it is unknown. Generic drug pricing and availability are important issues for the Commission because generics account for 90% of the drugs billed under Part D and 20% of the gross program spending. Although they are a fraction of the cost of their brand name counterparts, their price reductions have slowed in recent years, adding to the cost of the Part D program overall. Is that variation because they're often used in specialty pharmacies and many of them are vertically integrated and not vertically integrated? Asked the Commissioner Gina Upchurch, Executive Director of Senior Pharmacist in Durham, North Carolina. So another policy analyst for MedPAC replied, I don't think we have very good insight on why these particular classes have large variations, aka nobody knows. Things just get incredibly inflated. Americans are paying, 3 times the price of the cost of medication than every other wealthy country in the world, right? It's called balloon pricing. Insane. So, Commissioner Dr. Lawrence Castellino, of Weill Cornell Medical School in New York City, pointed to the frustration of Medicare beneficiaries feel in trying to understand and get benefits from their Part D plans, using his own generic cardiovascular drug as an example. So I recently started to get emails from one of the largest PBMs or pharmacy benefit managers saying that this drug is out of stock. Talk to your doctor about a substitute. Well, there isn't really that great of a substitute. And he tried calling the pharmacy benefit manager, which serves as his mail order pharmacy. But after 15 minutes on hold, what do you know? He hung up. He called back, and after another 5 minutes, found someone who knew what they were talking about. She said, "We don't have it, and we don't know when we'll have it," he explained. And this is one of the biggest PBMs in the world, and you don't know if it's going to be a month or 6 months. Person on the phone said to call around local pharmacies, and that didn't resolve the issue. How would one pharmacy chain be able to have this drug and this big PBM with its own mail order service not be able to have it, not just for a week or two, but over months, he posed. Now, he also noted that there are frequently multiple manufacturers for cheap generic drugs, and each wholesaler may choose one out of the multiple manufacturers, and the supply chain disruption could be related to that particular generic manufacturer. Commissioners say they want information on whether consolidation of the pharmacy marketplace has affected the price or the accessibility of prescription drugs, as well as the common, apparently legal practice of trying to make tying arrangements. Such deals are agreements between wholesalers and pharmacies that explicitly tie the size of the discount on brand name drugs to the volume of the prices of generic drugs that a pharmacy purchases. Under such arrangements, wholesalers may charge higher prices for generic drugs in exchange for larger discounts or lower net prices on brand name drugs. Independent pharmacies often consent to avoid losing money on branded drugs, even if it means paying more for generics. So, the MedPAC staff spent several months interviewing a variety of stakeholders to learn more about the supply chain interactions that influence such wide variability. The stakeholders told staff that they often face different acquisition costs for the same generic drug due to different prices from wholesalers, not the prices set by manufacturers. And differences in bargaining leverage played a role of costs, with large chains having, of course, more clout than independent pharmacies, aka the death of independent pharmacies and independent pharmacy deserts. Although, hope is not all but lost. But, the mechanisms behind pharmacy drug pricing appear to be so complicated that Commissioner Scott Sarin, Dr. Sarin, Chief Medical Officer of MoreCare in Chicago, called it a giant ball of yarn with all these threads, or maybe a hairball. Upchurch said that the impact has been hard on Medicare beneficiaries, especially since Part D began in 2006. The idea was that you would have a negotiated price at the pharmacy as long as it was in network. Now, she added, with irrational drug prices, beneficiaries in the know have to strategize across multiple means to access their meds. GoodRx over here, and a mail order program for Mark Cuban over there, and a patient assistant program over there, and many other methods that bypass the local pharmacists. Getting their prescriptions in this way often misses inclusion in the electronic health records, and thus increases the risk that clinicians will not be able to see potential drug interactions and other potential medication-related problems. Bad enough that the plans can dramatically change with what medicines they cover and what costs for each year with different utilization management tools, but then to have multiple sources of the least expensive drug is just too much for older adults and adults with disabilities. Think about it, right? So, Dr. Michael Chernow of Harvard Medical School in Boston called the staff's presentation eye-opening and agreed that the problems with generic drug in Part D are difficult to understand, much less solve. It's very hard to figure out what the solution will be. There have been many attempts to make reforms in a range of ways that we thought would help the problem, and then a bunch of other things seem to happen around that because of the complexity. So no good answers. That's where we're at, but we know, we got to continue to advocate for better drug pricing as a whole for all of our country's beneficiaries, whether you're a Medicare Part D member or just any sort of, commercial insurance benefit member, right? Everything that's messed up here is because money is being sucked out by the pharmacy benefit managers from the people actually providing the service, aka the pharmacies, or independent pharmacies, should I better say, and the patient. Those are the people who are doing it, and the American taxpayer, contributing to the funds, right? It's a big pile of cash that they have slimeballed their way into leeching for a really long time, and we are, suffering as a country for it. What can we do to be better? Got to keep talking about it. Can't let the pressure by any means cease. And so onward we push. All right, guys, moving on to our Tech Talk segment, talking about cryoablation. Anybody ever heard of this? Well, now you will.
What is cryoablation? This fascinating medical advancement is used to destroy the malignant cell while also gathering important information. Having access to good information will allow this form of therapy to then destroy cancer that's affecting the body. You may be wondering, what exactly is cryoablation? Well, it's a form of immunotherapy that involves freezing the tumor directly with a thin needle. It works best when used for early-stage cancer and is useful with immune-enhancing measures to reduce the risk of future metastasis. Does cryoablation really work? Cryoablation is so powerful that it can be used to generate strong immune responses, which can lead to one of the most successful cancer treatments that exist, especially for patients with stage 3 or 4 cancer. Another important note is that combining cryoablation with other forms of immunotherapy enhances the overall success rate of cancer treatment. Looking for a cancer treatment? Williams Cancer Institute can help.
So cryoablation is our highlight today in our Tech Talk segment. Just definitely want to bring some attention to it. Literally coming out at a big study out of Orlando, cryoablation without excision for low risk, early stage breast cancer may be an option for women over 60. 5-year follow-up results have just shown that at a mean follow-up of 54.2 months, the ipsilateral breast cancer tumor recurrence rate was 4.3% and the breast cancer survival rate was 96.7%. And the overall survival rate was 88.6% in the women who received cryoablation. Pretty insane, right? Breast cancer tumor recurrence rate dipped to 3.2% among women in this study treated with the adjuvant endocrine therapy following a cryoablation procedure. So, talking about freezing cancer with a needle, perhaps we get a little bit more of that information and access out there. Big highlight in our Tech Talk today. Not too much more to talk about, minus the fact that it's a big giant needle, penetrates, freezes cancer, elicits an incredibly strong immune response, not only for late stage 3 and 4 cancer, but also, right, for early stage breast cancer. So this is something that hopefully want to see a little bit more information on coming in the future. And perhaps, we get it actually integrated in a lot of our, local cancer clinics, right? We're doing a lot of 5-fluorouracil and all the other, big time intense, big pharma kind of drugs, but this, a non-pharmacological treatment, of course, endocrine therapy afterwards, but pretty promising and definitely want to bring attention to it. So there's that. All right, let's jump into our Enlightenment Hour. Talking about psychiatry and trauma. It's a cool one from Dr. Kevin of kevinmd.com, otherwise known as social media's leading physician voice. Coming up recent. Take a look at this. So he actually had a resident, I believe, a psychiatric resident that wrote this article on his page named Dr. Patricia Sealand. But anyways, psychiatry has a duty to be trauma informed, given that 50 to 60% of the general population and around 90% of people with severe mental illness have a lifetime history of at least one traumatic event. Yet the mental health system often falls short. Consider involuntary hospitalization in a psychiatric unit. Losing one's freedom can be traumatic for anyone and triggering for those with past trauma of non-consensual experiences. Sometimes the patients are unwillingly restrained through chemical restraints like sedatives or physical restraints that tie them down to a hospital bed. Occasionally, patients may be placed in a therapeutic quiet or isolation, spending several hours or days in a small locked room with no windows or objects besides a mattress. The defense is that they are unwell and their behavior could lead to harming themselves or others. Well, what else can we do besides confine them, sedate them, or physically restrain them and isolate them? Imagine you're the patient being stripped of dignity during that devastating experience. So when examining psychiatry's controversial history of patient mistreatment, we really need to take a look not that far. Problems persist currently in the present day. That's why planned reforms of the United Kingdom mental health system suggest creating advanced choice documents to request preferred treatment plans over possible involuntary hospitalization. The goal here is to modify the paternalistic model of psychiatry. Psychiatrists currently have excess control over independent human beings, enabling the undermining of adults that psychiatry ought to empower toward better mental health and emotional well-being. While one could hope that abusers would be unlikely to choose a compassionate helping profession, the ability to wield access power, right? Literally, think about that. With great power comes great responsibility, right? We all know where that's from. Again, the ability to wield access power against vulnerable people who often have insufficient mental, emotional, or tangible resources to stand up for themselves can appeal to the most powerful and power-hungry people in society. That power extends outside hospitalization, given that diagnostic choices can discredit anyone who displeases a psychiatrist. The framework of personality disorders is pathologizing and stigmatizing, perpetuating marginalization and social exclusion while failing to address the underlying trauma that often drives rigid and maladaptive behavioral patterns. Of those with personality disorders, 80% have a history of childhood adversity, and 91 to 92% of those with borderline personality disorder report a history of abuse or neglect. Healthcare providers largely do not approach personality disorder patients with an empathetic goal to understand and collaborate with the trauma survivor. The label personality disorder connotates difficult or bad stereotypes, leading to bias and diminished empathetic responses. If a patient expresses dissatisfaction with the healthcare provider or the system, causal use of personality disorder behind the patient's back serves to soothe the bruised egos of healthcare providers who feel underappreciated. Psychiatrists need to abandon the egotistical hunger for paternalistic power and insincere praise, instead showing humility and accepting feedback from unhappy patients. Cultivating disdain, even in private, does not help anyone. A failure to cultivate genuine empathy can lead to blind spots, inadequate treatment, and devastating outcomes. Suicide risk is highest among those with personality disorders. So psychiatry's struggle to effectively address trauma stems from reliance on outdated paradigms, overlooking the complex interplay between adversity and mental health outcomes. The historic sexism of hysteria continues, rebranded as histrionic or borderline, while labeling women as emotionally unstable. Even the language around suicidal ideation reveals stigma. Although a desire to die is merely evidence of suffering, psychiatrists are taught to use the label as suicide threats, an archaic holdover from the days when suicide was considered immoral and a crime. While dialectical behavioral therapy is popular in treating personality disorders, its behaviorist approach often ignores the underlying trauma. The idea is that behaviors influence thoughts and feelings, behave better, think better, feel better. Right? Yet by focusing on modifying behaviors and teaching coping skills, DBT may inadvertently suggest that symptoms solely result on individual deficits rather than addressing the role of the trauma in shaping maladaptive patterns. Dialectical behavioral therapy's emphasis on acceptance and change dialectics can inadvertently invalidate survivors' experiences by promoting tolerance of distressing situations without addressing the traumatic impact. This may perpetuate feelings of shame and self-blame, ultimately hindering the healing process below surface behaviors. Changing behaviors to hide, mask, or camouflage pain may only mean living a life in secrecy while the pain continues, internalized. Patients who express dissatisfaction with DBT complain that they may function better in society, but on the inside still aren't happy, and they're just too afraid to admit it, lest they get a resistant label. So the time has come to dismantle the fundamentally flawed construct of personality disorders in order to effectively treat trauma survivors. Rather than pathologizing individuals, diagnostic criteria should reflect the complex interplay between trauma and functioning, recognizing the heterogeneity of trauma responses and addressing the role of environmental factors in shaping outcomes. Research has shown promising results in treating personality disorders through trauma-informed approaches. Intensive trauma-focused treatment can lead patients who screen positive for BPD to experience decreases in symptoms such that up to a third no longer screen positive after only 8 days. The label narcissist is highly overused and vilified, yet many know that narcissism is a normal developmental stage that most children outgrow unless trauma keeps someone stuck. Most adults with narcissistic traits have unresolved trauma. Selfish, unempathetic behaviors can simply be defenses that were previously somehow adapted, which means treatment is possible from a compassionate provider utilizing intensive trauma-focused treatment. The TEMPO study, otherwise known as the trauma-focused EMDR for personality disorders among outpatients, is the first randomized controlled trial investigating the effect of intensive trauma therapy on personality disorder severity at a 1-year follow-up. If the results show significant improvement in various personality disorder symptoms as a result of trauma treatment, are they really personality disorders, or are we overdiagnosing problems with the person and underdiagnosing trauma responses? So psychiatry must enhance understanding of heterogeneous trauma responses within and widen the umbrella of trauma disorders. Only by embracing a trauma-informed approach can we truly provide compassionate, effective interventions to promote hope, healing, and resilience for individuals struggling to overcome the lasting effects of suffering adversity. A lot of great food for thought there. I think is a great article by Dr. Seelan. Again, I'm not a psychiatrist, but I think this can resonate with a lot of people, whether you're on the receiving side of the therapy or if you are a healthcare provider in any other regard, right? I mean, from the pharma world, I've seen so many mental health patients that are on the gambit, right? This is a Ferris wheel of medication. This doesn't work, go to this, and then, right, changing providers, whatever it becomes, and it becomes this incredibly vicious cycle of nothing ever getting fixed. How do you break a cycle? Food for thought. All right, guys, we're going to move on to our Herbal Wellness Corner, brought to you by Horse Cannabis Company. Hope everybody's shopping High Horse. For all the guys, the pre-420 deals are insane right now. Go check out that website. I'm telling you, pre-420 specials, and then the 420 deals getting announced Wednesday. It's going to be money ball, full show. So very excited to continue promoting all of that, guys. Had a great time doing our live stream over at the main store on Friday. And we've been getting after it in the lab, packing flour, cooking gummies, you name it. But anyways, we're talking kind of refreshing, right? Cannabis and drug interactions. Excited to be presenting about this at the New Mexico Pharmacist Association mid-year this summer. So, getting a little seat time. Anyways, so talking, is it dangerous to combine cannabis with other medications? Well, cannabinoids, they share metabolic pathways with other drugs, both using the cytochrome P450 enzymes in the liver. So a study by Stout et al. Concluded that studies of THC, CBD, and CBN inhibition and induction of major human CYP450 isoforms generally reflect a low risk of clinically significant drug interactions with most use, but specific human data are lacking. Most of the data comes from in vitro test tube studies using human enzymes, and results could be different in a living person. So in clinical experience, at least from what I've seen, drug interactions at low and moderate doses of cannabis are uncommon. So knowing the cytochrome P450 enzymes that metabolize the cannabinoids can allow a medical professional to look up the metabolism of a pharmaceutical drug and determine if there may be a drug interaction, right? Talk to your doctor if you're going to start cannabis and you're on other medications. Talk to your pharmacist if you're going to start cannabis and you're on other medications, or if you're curious, right? Don't go make assumptions for yourself. Sure, you can do your own homework on the back end, and I'll teach you how to do it, right? But this is about making sure that you check all your boxes and you get, right, all the approval that you need to begin low dose or moderate dose cannabis therapy, right? Or if you're a frequent cannabis user and you don't necessarily haven't really thought about it, does cannabis interact with any other medications I take, so on and so forth, you should probably put a little thought into it. And again, ask your healthcare provider for sure. So anyways, knowing the cytochrome P450 enzymes that metabolize the cannabinoids can allow a medical professional to look up the metabolism of a pharmaceutical drug and determine if there may be a drug interaction, as previously stated. Cannabis can also be found in some online drug interaction checkers such as Medscape. If you look up the synthetic forms of THC and CBD and the brand name form of, Marinol or generic Dronabinol or Epidiolex, which is CBD, right? Marinol, THC, synthetic, but it's very high dose. It's not generally what most people take. So cannabis can also be found right? In those drug interaction checkers, if you've never used a drug interaction checker before, again, talk to your pharmacist on how to use that, right? But it's ultimately, that's the job of the pharmacist. Let them put that clinical knowledge all together. And anyways, most interactions in general only occur in patients using those real high doses of cannabis. And I'm talking like hundreds of milligrams, per dose, right? So the cytochrome P450 enzymes used in cannabinoid metabolism for THC and CBN are CYP2C9 and 3A4. For CBD, it's CYP2C19 and 3A4. So there are some medications, right, that should use caution and actually truly discuss potential interactions with their healthcare providers, aka warfarin, that's the big one, or Coumadin, brand name, blood thinner, big time. If you're starting that and you're already on cannabis, or if you start cannabis and you're already on warfarin, you really need to have that conversation about what you're going to be doing, how you're going to be doing it. You can add things in if you're on warfarin, because just about everything you eat and every medication you take is going to affect your INR levels and affect, the way that warfarin is metabolized in your body, aka decrease the amount of blood thinner in your body, which thickens the blood, or increase the amount of blood thinner in the body, which thins the blood. And if you've got it way too thin, what happens if you fall, hit your head, right? What happens if you get a cut and you start bleeding? You have very severe bleeding. You could be getting, some extreme bleeding in the brain, things that you really don't want. Maximum doses of statins. Again, and I just had this conversation with a patient the other day. Low dose statins, we're not worried about. But maximum dose statins, like torvastatin 80 milligrams, right? Not, 10 milligrams with high dose cannabis, that could be potential for, adverse drug interactions, aka increasing the risk of muscle pain and weakness from statin medications. Again, this is talking high dose for both. So, most people generally are on relatively low or moderate doses of statins, and most people aren't really on incredibly high doses of cannabis. But you never know when that situation could be. Another one, antibiotic, erythromycin, or azole antifungals. Those could be ones, right, that you definitely want to check out in terms of, am I on cannabis? What is going to happen, right? Other things. Did you know that, right, anticholinergic drugs like Benadryl or Dramamine, even inhalers such as Spiriva or Atrovent or Wellbutrin, aka bupropion, right, Congentin, these could all potentially worsen the adverse psychiatric effects, psychoactive effects, right, of cannabis. And so using cannabis to relax when you're already on some of this other stuff, could be something that you have to take a double look at. Again, really depends. But, at the end of the day, I don't want anybody to come to their own conclusions. If you have a conclusion, go triple check that with your healthcare provider. Go drug interaction, double check it, right? Triple check it with your doctor, with your pharmacist, and just make sure you've done your homework, right? Again, cannabis can be such a great drug. It can be awesome to replace a lot of these anticholinergic drugs that we might use for sleep or for nausea, or other anticholinergic drugs that we're using for the mental health side of things, whether it be anxiety or psychosis. But cannabis can also be bidirectional. Some people it can affect differently. So again, because of the genetic responses that also happen with cannabis that we're not fully aware of, it's very important to consider just how it is going to be at such an individual level. So understanding your risk before you incorporate cannabis into perhaps your regimen for whatever reason it may be, pain, sleep, anxiety, look at the top common things, or other kind of uses and healing therapeutic uses. I mean, it's a really big deal to just overall talk to your healthcare provider. Don't go do anything on your own, right? We all want that autonomous, self-control. We all want to be in charge, but when it comes to turning yourself into Frankenstein, I highly advise against it. And that's our Herbal Wellness Corner, brought to you by Horse Cannabis Company. All right, guys, Community Spotlight brought to you by the Big Chicken Farm. Pulling at the heartstrings around here in Las Cruces. And I don't consider this by any means sad. But I know a lot of us, used to play Little League back in the day. A lot of us want to give back, and Las Cruces Parks and Recreation is in need of T-ball, 6 and under and 8 and under, and coach pitch 10 and under coaches. So if you're interested, please reach out to Mearshite Recreational Center at 575-541-2563 or athletics@lascruces.gov. Want to make sure, all those, perhaps you have kids that are in it, perhaps that you're interested for whatever reason you want to give back because you had great experiences as a youth. Now's the time to get into it, right? Community Spotlight brought to you by the Baked Chicken Farm. Go out there, enjoy people, be around sunlight, get outside. This is a great way to do that. Don't be a crazy ump. Don't be a crazy coach. We all know who you are. We've all experienced, crazy coaches, crazy umps out there getting lit, whatever you may call it. But go give back. This is a beautiful way to do it. Hit up Las Cruces Parks and Recreation. All right, last thing, guys. Our Men's Health Minute brought to you by Vado Speedway Park. Talking about men's health e-programs here, but promoting men's health with the Don't Change Much e-program. This is pretty cool. The concept of the Don't Change Much here, I think it's very practical because it's not talking about, completely transforming your life and flip-flopping things upside down, right? It's talking about using e-health programs to, literally kind of give an individualized way to help, right, meet certain health benchmarks, right, and talk about intended behavioral health changes without, entirely, trying to make it such a stressful experience, right? So talking about this, it's interesting, men's health issues, including prostate cancer, HIV prevention, weight loss, health screenings, have all attracted e-health promotion programs, and there's much debate about the effectiveness of these interventions. Relating in part to the predominance of needs analysis and acceptability studies wherein feasibility and or design of e-programs are informed by potential male end users. That's what we're talking about, right? The Don't Change Much mechanism here was pretty successful. And so there's still going to be needing to be more, again, data and more technology that comes out because not a lot of this tech has made it entirely to market per se. But what is, good about this is looking at practical ways to help kind of change the, perspective and give a paradigm shift for men's health. This weekend, for instance, let me talk to you. I was giving health screenings all weekend long, Friday, Saturday, and Sunday with the Horse Cannabis block parties. I'm talking to men specifically, men that don't go to the doctor, which is a very common theme there. It's like, well, I'm doing okay. I don't even want to know if I'm sick. I don't want to know if, I'm bad off, whatever it may be, right? And so you really look at, well, what if you could know without having to spend a whole lot of money? Or what if you could know on your own time and not have to have some, person look at you in the eyes and make you feel judged or whatever that may be, it's very interesting to think that, this current study really did have statistically significant positive associations between the men's Don't Change Much exposure levels and their recent and intended health behavior changes. So yes, 3 issues as a means to scoping, Don't Change Much adjustments and offering recommendations to, platforms that are offering out and advancing men's health promotion work. So, the first one was talking about recent changes in change diet or improved eating habits and made an effort to sit less and walk more, right? So talking about instead of getting out there and having some wholesale change of, right, or abstinence of, getting out there, getting pumped up and exercising hard and becoming some sort of army style, fitness training program. It's just talking, get more steps, right? Try cooking at home and eating a different variety of foods, right? Reducing stress and improving consistent sleep quality also, right? Featured predominantly as other, big time phrases here. Helps with, underscoring the importance of don't change much, right? But can we promote healthier sleep, which in turn is going to turn around a whole lot of other positive health benefits on the back end? Can you talk about stress management in a way that, maybe can be a little bit more resonated with? So these are the things that don't change much. Framework is pretty awesome. You look at how it can be employed and deployed. I don't think there's a whole lot of technology out there that is hitting this yet, but again, this is a step in the right direction, and I hope to see men's health trend this way, because these little subtle adjustments and ways of, individually kind of discovering and transforming yourself, is going to be that way for men to be able to do it. And you talk about e-health, men don't want to go to the doctors. You don't want to go and get the appointment. You don't want to go all the way out there. You don't want to do all the things. Maybe you don't have time, on top of money, on top of, whatever other perceptions there, and fear and, shame, or whatever that could even be amounted to not get checked. But the more you could do from perhaps your phone, and the more that was not pushed on you, but empowering you, and find perhaps better health results. So anyways, talking about a vision for the future, I like the Don't Change Much framework here in our Men's Health Minute, brought to you by Vado Speedway Park. But that'll be it for tonight, guys. Hope everybody has a great one. See you tomorrow.